everyone, it's Dr. Rick. Today my idea would be to talk about diabetes. I've had a couple of patients that are coming to me a bit on the frustrated side. Weight issues. There's hemoglobin A1C issues. That's the glucose level that's done every 3 months to see how much exposure the red blood cells had to glucose in the bloodstream. There's several different classifications for diabetes. There's insulin-dependent diabetes, there's non-insulin-dependent diabetes, also known as type 2 diabetes, which used to be called adult-onset diabetes. But believe it or not, in the last 20 to 30 years, because obesity has really become rampant, and by proxy, when you're obese, it's only a matter of time before you become a diabetic or into the family of diabetes. So those of you who are pre-diabetic, glucose intolerant, insulin resistant, type 2 diabetes, type 1, doesn't matter. The bottom line is that some people will have a problem processing glucose. Glucose is essentially carbohydrate, but it's a fuel source. Every cell in the body has a mitochondria, and that little powerhouse of the cell or the factory of the cell works to organize energy, ATP. When you eat, your brain's supposed to help you look for food. The nutrition that you prefer after it's broken down and digested gives you those fuel sources. Whether it's proteins, fats, or in this case carbohydrates, all of them theoretically can be used as a fuel source. The easiest fuel source that we are most readily able to use or deploy would be glucose. And glucose, everybody calls it sugar, but it's not really sugar. That's a layman's term for referring to glucose. Just for the sake of our discussion today, I want to point out that the fuel source that you choose or you utilize is dependent on your eating pattern, the way insulin and glucagon work. Those are two hormones that work in opposites to either get the insulin from the blood vessels into the cell to be utilized as fuel, or put the glucose that we just digested and processed into our storage for later energy, and that would be fat. The problem nowadays is that a lot of the diets that the U.S. is exposed to, fast foods, processed foods, desserts, candies, pops, high fructose corn syrups, all those things, especially in COVID, enticed the country to become overweight. For COVID, we've all gained weight, and we've had the luxury of being able to stay home and just have food sent over or delivered to your door. You don't even have to pay with cash. You just use your card over the phone. Within 20 minutes, your meals are delivered. It has allowed for even less activity and mobility, which adds to the problem. So before you know it, a lot of my patients that are just really struggling and frustrated and confused, a lot of them are in their 40s and 50s and are just overweight with elevated glucose, probably elevated cholesterol, blood pressure, and then the mood that goes with it. So there's a constellation of different symptoms that get adopted when you become overweight. The best way to move forward into a healthy lifestyle that reverses disease is to take accountability of where we are right now, because you have to have metrics as far as measurements of body weight, waist size, hip size, fat composition, lean muscle mass. Impedance monitors can tell you what your fat estimate is. Fat calipers, there's something called a DEXA scan. It's nice to know all that stuff, because moving forward, if you can keep your motivation going for the investment, that's great. If you cannot keep your motivation for the investment, that you're seemingly sweating bullets, putting out money, starving yourself, well, sometimes if you don't see any movement of the needle, then it's like, why am I even doing this? When in actuality, it does take time before lifestyle change will manifest physically and on metrics of blood. I like to say when we're first starting out, especially those folks who haven't exercised in a decade or two, or never exercised at all, or never dieted, or tried dieting, but it was very frustrating and stopped immediately, I would break into having them adopt a lifestyle change, build muscle, build endurance, get used to lactic acid, try to work on nutrition, little baby steps. And it's sometimes considered threatening to tell somebody to go work out in the gym. To throw another curveball in there, also older individuals, silver-aged, that haven't been to a gym, that don't know what to do, that can sometimes hire a trainer. But again, when the trainer says, I want you to do some resistance exercise and lift weights, and then you put those two, husband and wife team, in the midst of young people sitting in front of mirrors, working out and grunting and throwing F-bombs, that too is a little bit discouraging. And that's why it's sometimes nicer to have a softer entry point. So as best as possible, if I can use medical insurance to initiate that training process as far as activity, I would. In fact, I've spoken to many patients and I've found they have weak cores, they have bad knees, they have shoulders that they can't lift over 90 degrees, they have neck pain. So, or with people who have fibromyalgia, chronic fatigue syndrome, if you overinvest and you're not ready for it, you're going to have that delayed onset muscle soreness that just might last more than a week. And that's discouraging too. So that's a deal breaker. So you have to take all those things into account. So if you can get to a physical therapist to first strengthen your weakened areas, have them graduate you after a couple weeks, do things on your own. Maybe if they're also certified in athletic training, they can develop a home exercise program that you can apply at your gym or your house. Typically, I don't like working out at the house. I think the possibilities for sustainable exercise are low because it's just very boring. Whether you have an elliptical, treadmill, or you're lucky enough to have a setup in your house, even if you have the fanciest setup, it takes a lot of fortitude to maintain that through 12 months. Now, if you can see goals, if you have workout partners, if you belong to a box or a CrossFit gym, I think those things are awesome. The only problem is COVID and exposure. I'll talk about that in an up-and-coming video on COVID. Try to establish a successful team that will guide you with your activities. And I don't mean just beginning. You have to have somebody follow through with you and keep on adjusting depending on your level of expertise and your comfort. Oftentimes I'll see people that invest in a trainer of some sort. They initiate an exercise routine, they sustain it, but then they don't make contact again. And I think it's very important to have frequent touch points with your team, nutritionist, to help guide you as far as changing metabolics, because it's always dynamic. It's highly possible that if you stick to one nutrition practice, your body will be accommodated to it and it might not serve you. So it's always good to keep your nutritionist in your pocket. Activity definitely needs somebody to give you some guidance and fine-tune as you become accommodated and stronger to the activities you're doing. The last thing is mindfulness or meditation. I think that usually will hold itself. I think with what I've experienced, once somebody has learned a technique, they'll be good at sustaining it and it never becomes boring, versus the nutrition and the activity portion of lifestyle change. So in the case of hemoglobin A1C, like I was alluding to, if you have a high hemoglobin A1C, say greater than 9, it's okay. Don't be embarrassed, but you'll probably need a little bit of medical help, meaning medicines. And metformin is a typical one I used to give in the clinic when I worked for Advocate. I did not want to piss off the endocrinologist, so I obliged and kept with the orals, and those are just metformin or sulfas. I don't like sulfas. They typically cause weight gain and you can bottom out your glucose really fast. Metformin, the pill, is still suggested has a good entry level. I've always leaned into berberine better than metformin because I did not like the bloating that metformin caused. But metformin is good because it doesn't bottom you out as far as glucose, and a low blood glucose can actually lead to death. Although it doesn't, because most people will kind of feel when they're going low, so they just eat a candy bar is what you'll hear. That's the old-fashioned way when everybody used to give insulin. And that used to be a common threat, was if you didn't control your blood glucose with your nutrition and exercise, you'd be getting insulin soon. So it would be that everybody got insulin. Short-acting, long-acting, then they came up with ultra-long-acting. They were all helpful if you were advanced, but we were giving that to even people that were not advanced, just mildly diabetic. That means prediabetes, type 2 diabetes. And I think that's wrong. I think there's a place for insulin, especially if you're having symptoms. But for the majority of patients that I see that are not having symptoms, you're just having the numbers. All those folks with metrics that are high, weight scale, BMI, waist to hip ratio, blood pressure, blood glucose, insulin levels. All those people can start with lifestyle change. If you have symptoms, then you probably should get to your doctor for either single therapy or dual therapy. That means medicines, until you can get your lifestyle modification to make a dent, and then perhaps take another snapshot of blood metrics and then see if you can pull off of the medicines. I think that's fair. Sometimes when you lock yourself into like a Biggest Loser kind of a scenario where you drop down your calories to zero and you exercise the heck and do cardio all day long, you will lose weight, but your basal metabolic rate, your metabolism, will reset itself to a lower level, a starvation level, so that even the lower amount of food that you would eat with all the exercise would still make you gain weight. So you have to be careful you don't walk into the Biggest Loser phenomenon. So that's where, again, lifestyle modifications have to be developed in the short run and in the long run. I think it's important to look at the successes, look at the weaknesses of the individual, see what the resources are, and then design a program while putting together a lifestyle education process of learning about macronutrients, perhaps decreasing the carbohydrate count, increasing your protein, especially if you're older than 50, or a well-formulated ketogenic diet. All those things have a place. Even a vegan low-fat diet will work, but you always need to have them well formulated in order for them to be palatable and sustainable. So don't feel bad if you first have to start out by doing baby exercises. Don't feel bad if your doctor says, we're not going to lose weight at first, we're just going to work on metabolism. Don't feel bad. Don't feel bad if we just fix your sleep, fix sleep apnea, maybe put you on a cholesterol medicine, 1 or 2 glucose medicines or glucose lowering medicines. I'm okay with metformin. I would probably lean into an SGLT2 inhibitor or a GLP-1. So both of those are the newer medicines, unfortunately mostly just injectable, but they do have a lot of great benefits if you can get them covered by your insurance. Some will protect you from heart failure, some will help you lose weight quickly. Both of them will not bottom you out, but they'll accentuate your lifestyle modification. So that's why I like them. Metformin, the old one, or if you go with my suggestions on berberine, they both are very good, but they have to be dovetailed with a lifestyle modification program. So whatever you're doing and however deep that you're into this crap, don't feel you're alone. If you have a doctor that's just giving you metformin and insulin, it might be reasonable, but you can always consult me on my Herbal 411 webpage. I think that if we're working from a distance, I can at least see what your nutrition practice is, guide you as far as fine-tuning the macronutrients, the calories, the timing per day, fasting, give you a template of how to increase your exercise, build up endurance, improve metabolics, and then start to reverse this stuff. But you have to be patient. I always dovetail it in with making sure you have mindfulness. Mindfulness when you're super hungry is very important. Mindfulness when you're trying to get to sleep is very important. It's a necessary evil that a lot of my patients don't embrace, but it's okay. So hopefully this gives you a couple of ideas on knowing that lifestyle modifications will work, but they have to be personally designed, empowering you to deal with the medicines that your doctor's giving you. If there are side effects, report them. If there's no side effects, fine, but work your ass off to make those lifestyle changes count so that you don't have to be on these medicines forever. It's always going to be a challenge. Don't feel bad if you're sugar craving or sugar addicted. We all are. That's a normal human response to processing of food. The medical community, or maybe the food industry, is making you think that it's your addiction and you're weak, so you shouldn't be doing it. But there's more to it than that. There's a lot of kinetics that move around when you're talking about food, cravings. That's why I mentioned sleep and mindfulness is really important. When you have all stress response all day, no love or rest rebuild response, you're going to be off center, and sometimes that off-centered feeling will allow you to slip into craving and eating snacks. Get some help. It's not that bad, and even if it is that bad, it's going to be temporary as long as you invest. Don't be a prisoner to the medicines that your doctor says you will be on for life, and just keep on working to make the best life choices you can. Thanks for watching up to this point. Don't forget to subscribe to me or share this with other people who might be on the fence or might be bullied by their doctors into fat shaming, and I'll see you in the next video.